And I want to thank you so much for the invitation to be here. It really is an honor to be here. So I'm very delighted. I do serve as the third vice president of the American Institute of Ultrasound in Medicine. I'm also the governor of the Prairie Provinces chapter at the American College of Physicians. I don't get payment for these works, so it's not really a financial conflict of interest. The only potential slight industry related is the Medical Clinics of North America, where I did get an honorarium for serving as the guest editor, but I don't get a royalty from this. I otherwise do not work with industry or for-profit organizations. This is where I'm from, University of Calgary. We're located just east of the Rockies, and with that comes the benefit of lots of hiking in our backyard. All of these are just from like a few from my hiking collection. They're all within 2 hours away from our backyard. So, and if any of you find yourself in Calgary, look me up. I'll be happy to show you around. Actually, Calgary itself is not nice. You have to kind of get out of it. These are the objectives. I want to talk about safe use of POCUS. I think a lot of us are familiar with a little bit of POCUS, right? So where do we go from there? I wanted to talk about how we take steps to become a safe practitioner and what are the things that systems can do to support us in what we do. Good thing to start with a case. We have a 40-year-old man who is post-liver transplant on all the usual immunosuppressives. He's presenting with nausea and vomiting. He's afebrile, he's hypotensive and symptomatically so. Otherwise, respiration is okay, satting okay on room air. His jugular veins are distended. His chest is totally clear on exam, and he had very significant bilateral pitting edema. His chest X-ray, not super impressive, no pulmonary edema, maybe a tiny bit of effusion in the right base, the hemidiaphragm's elevated, and maybe a little bit of consolidation, but certainly nothing dramatic to be explaining his hypotension. So the senior resident on call overnight did POCUS and said there's no pericardial effusion. So what's causing this JV distension? We don't really know. So a CT was ordered. That was negative for PE. ECG was unremarkable, nothing cardiac going on. The attending the next day received this patient and is like scratching her head. What's going on? Why is the JVP up? Doesn't really make sense. Got the POCUS team to reassess the patient. Now, you guys actually went over in CPC rounds yesterday. So this is a parasternal cardiac view, and I've labeled what a normal one would look like. What you can see is actually pericardial effusion here and here, okay? Circumferential pericardial effusion. And if you do a transverse view, it's not the greatest quality, but still you can definitely see, again, a circumferential pericardial effusion also seen in apical four-chamber. Relatively confident that we're dealing with a potentially significant pericardial effusion. Guess what? IVC is also completely distended, no respiratory variation. Mitral inflows were also significant. Ultimately, the patient was determined to be definitely in tamponade. Urgent pericardiocentesis was performed. 250 cc's was tapped. Patient was ultimately diagnosed with effusive constrictive pericarditis. So what went wrong, right? What went wrong was that we think, and we don't have images to compare and confirm, we think that the senior resident on call thought that this area was just a RV outflow tract. That's what a normal would look like. You know, potentially you can understand why that may be mistaken for the RVOT. What actually happened here is that the effusion was so significant that the RV was completely flattened. Okay, so that's one of the dangers of suboptimally performed POCUS. And I'm not picking on any house staff at our site or even attendings. Let's just say that mistakes can happen in POCUS. So there's the reason why we need to be very careful about what we do. POCUS can be harmful if we misapply it, either because our scanning technique is not amazing, or we're not interpreting correctly, or we're not integrating correctly. So in this case, it's really fortunate that we had an attending who knew nothing about POCUS, but at least she sat there and said, this doesn't make sense. It's not PE, JVP is up, you've got edema, patient's hypotensive, something's going on. You tell me there's no pericardial effusion? She didn't trust it, right? So it was really fortunate that she had good clinical skills and actually asked the right questions. So my point is, using POCUS safely is critically important. How do we, as individuals, make sure that we practice as safely as we can? One of the things that we do is to ensure that we meet minimal criteria on our images. POCUS is not about obtaining the best ever image you can get. The POCUS is about getting just good enough for you to make the calls that you're going to make. If you don't meet those criteria, you shouldn't make them. Okay, it doesn't need to be perfect. POCUS is not perfect. Sometimes I'm running around only 5 minutes to scan my patient, right? So this is one example of an article that we published on what minimal criteria should be. This is taken a lot from the emergency medicine literature, where they have very clearly defined rules and regulations about at what point are you okay to call a lung scan, right? Like you shouldn't necessarily make calls on every one of them, but once it meets criteria, you can. The worst mistakes we can make is to say things like, I'm not sure what I'm really seeing. It's not great, but it's, probably nothing there, right? Those are the kind of comments that we make as POCUS practitioners that are super dangerous. And I sometimes need to, sit down and really think through. It's like, do I meet minimum criteria? If I don't, I'm just going to say no information, rather than that's probably not important, right? Like, so those are the things that we as practitioners need to be very, very careful in making calls when you don't meet minimal criteria, because no information is better than bad information. What I tell our house staff is that we need to aim to be 100% correct in POCUS, okay? If I'm going to call something, I better be able to bet my life on it. Occasionally I'm still wrong, okay? But it should be extremely, extremely rare. So if you're going to call something, you better be sure, because POCUS is at its infancy. What happens if you make a mistake is that other physicians who don't know POCUS is going to look at it and say, POCUS is stupid. Look at them, right? So this is a highly charged situation where mistakes is going to cost you significant reputation, and therefore our job as POCUS practitioners, no matter what level you're at, is try to be as correct as we can in all circumstances. Other things we can do, have a decent approach. You have an approach in internal medicine. Let's use that same approach in POCUS. We're going to compare sites. We're going to thoroughly investigate a finding, right? We're going to think about all the issues that go with that. So this is a nice slide that illustrates the problem with interpreting only one view, right? So if you only see one view, you get a very, very incorrect conclusion. So the common saying in POCUS is, one view is no view. And I think in the case of that last case, if the resident had done 2 views, maybe they would have been less likely to miss the significant pericardial effusion. Scope. We need to think about why we do point of care ultrasound in the first place. There are things that it's not appropriate for. It's not appropriate for ruling out AAA. Most of the time, our patients have tons of gas in the abdomen. There's usually a little bit of bowel that a little bit of aorta that I can't truly see well enough, so I don't rule out. However, it is very appropriate that if you see a clear AAA on ultrasound, that at my institution, my vascular surgical team is actually at a different hospital. If I see a AAA, I will activate vascular surgery and talk to them about a transfer right away, rather than kind of wait for formal imaging to confirm and things like that, right? So if you see a clear abnormality, act on it. What's not appropriate? What lesion is that? I get asked random things like that all the time because I do POCUS, right? They'll come up to me and say, oh, what do you think this lesion in the kidney is? What do you think this lesion in the liver is? It's really important for us to acknowledge our limitations. We're trained as point-of-care ultrasound physicians. It's not our job to fully evaluate everything. I have a lot of respect for our radiology colleagues. If I wanted to be that, I should just do radiology, right? So recognizing our limitations is absolutely critical. However, like, what can we do? Yeah, I'm really comfortable calling ascites. Like, I am so comfortable calling that I feel like I don't need radiology input for that, right? So I think where you are you really need to think about the scope that we're able to do. POCUS has the danger of being ultrasound-based and therefore gets conflated with radiology, echocardiography, MSK radiology. It's very, very common for people to think, oh, like a cardiologist approach is going to be way better than what you do. Or MSK radiology is going to be way better. It's not better or worse, right? Like, they definitely have skill sets that I don't have, right? Or that we don't have in point of care ultrasound. But it is important to know that what we do is its own beast. But our beast, we need to do it really well. The analogy I have is that POCUS is a bit like serving in a food truck at a folk festival or something like that, folk music festival. We are catering to thousands and thousands of people coming in wanting burgers and whatnot, and we need to do it well. Just because I'm in a food truck doesn't mean I don't wash my hands, right? Like, you still have to do it well. You have to serve good food. You still have to have the right hygiene to cater to the masses. Yes, a Michelin star who spends 60 hours preparing the base ingredients for your meals has a much higher skill set than I do, but having a Michelin star in my food truck isn't always helpful. So that's the kind of analogy that I think about POCUS. We are its own beast, but we need to do it well. Other things to think about, we need to think about differentials, false positive, false negatives, artifacts, pitfalls. These are all the things for every application we need to learn. I'm going to move quickly to why figuring out whether or not someone is able to independently practice POCUS is really important. Up until this paper came out, all the papers on lawsuits in POCUS up until then had been, you get sued if you don't use POCUS when indicated. Okay, up until then, that's always been the saying. You're not going to get sued. You're only going to get sued if you don't use it when you should be using it. This changed the landscape. This is a study that looked at a decade of lawsuits involving POCUS in Canada. There were 15 cases where POCUS was a problem, and all 15 cases, it was counted against the physician. Diagnostic error was the most common reason we get in trouble for. 16% involve residents, 58% involve those who are just in practice. So early career residency, those are where most of the mistakes happen. And more importantly, you can see, I don't know which center this involved in, but internal medicine is no longer exempt. So 5% of these cases actually came from internal medicine. All right, so we do need to be cognizant about how we do POCUS because it may happen, lawsuits. And lawsuits are not even that common in Canada, right? So they're very, very rare. I suspect that it could happen in the States as well. ACRI is the Emergency Care Research Institute, which is a nonprofit organization. They labeled POCUS as one of the top 10 health technology hazards in 2019. They're not wrong. Their reasons was that point-of-care ultrasound adoption is quicker than the safeguards that are being implemented. Okay, so this is one of the reasons that we really need to sit back and really think about how do we do POCUS safely. They didn't just kind of say, oh, don't do POCUS, it's like such a disaster. They came up with suggestions, right? Like, how do we do this safely? They think that we should have POCUS committees, there should be oversight, there need to be standardizing the use. You need to have policies and procedures that cover training, supervision, demonstration of competency, credentialing, and so on and so forth. Individual specialties, such as internal medicine, we need to say, like, what is our scope? How do we provide coverage? And what are our scanning protocols? I'm going to go and talk a little bit about certification because I think that's an interesting educational topic that I'd like to explore. It's like giving someone a driver's license, right? You pass an exam, you get a license, you should be independently practicing and you should be credentialed to do point-of-care ultrasound. I think that's a relatively common approach. I just wanted to kind of go over the potential limitations of that approach. This slide shows you the common elements in certifying someone, right? Most of them require that you take a course, you have some hands-on, get some feedback, certain number of scans you should be doing. Some of them will say how many have to have pathology in it. They should be supervised and reviewed, send in a portfolio. You should have some sort of a test and assessment, and then you need to maintain your certification. But the million-dollar question is, does certification indicate competence? Or could it, right? We all know individuals who are certified and really are a little iffy, right? I mean, I think we've all seen that. We've also seen individuals who are amazing without any single certification. Okay? I'm not saying like toss this whole certification system. I'm just outlining that there may be some problem with it. The problems come from the fact that assessment is really, really hard. Okay. I'm not going to bore you with too much details, just some examples. Point-of-care ultrasound assessment is crazy complex. Like our learners have to acquire images, they have to interpret it, then they have to clinically integrate it. With it comes like their time factors. Patient might be fighting you. And yesterday, those of you who were in the room with me saw some of my cases of shoulder exam where the patient was literally punching us as we were trying to get an exam, but we still could determine that there's a shoulder effusion. But all those things kind of come into play. This is a study that kind of broke down what the components are with regards to someone acquiring an image and interpreting in red, acquiring in blue. This isn't even all of them. A month ago or 2 weeks ago, I was in Trento, Italy, where a lung ultrasound conference was there. The Italian engineers were actually developing a protocol on using robot arms to do image acquisition. For something as simple as lung ultrasound alone, a single image required 328 individual movements to acquire. So what's a common approach that educators take when we have to deal with acquisition, interpretation, and integration? What are you going to do? Let's break it down, right? Let's do an exam. Let's just show me how you acquire the image. I'm going to then give you another exam, and I want to see if you can interpret it. A whole bunch of like 100 images. Great. And then maybe for integration, we can sit down, do a written exam or oral exam and OSCE, you name it. These are all the formats that we can do to examine these. Issue number 1, assessing skills performed in isolation may not accurately estimate ability to perform the whole task. Here's an example. I don't know how well that's showing up. This is an image that shows that maybe the pleural line is a little bit irregular, the pleural line being right here. This is a rib shadow, pleural line. It looks a little blurry and a little potentially irregular. However, if someone with actual better fanning, this is a totally normal pleural line. Nothing wrong with it, okay? So what happened there? So someone who may be generally really, really good at acquiring images have this one minor mistake called an irregular pleural line when it's actually normal. Normally, this person's great at interpretation. Normally, they're good at integrating, but that one mistake made them start in antibiotics inappropriately. You already saw that RV problem that I showed you earlier. That learner acquired the image okay, completely missed the fact that this was significant pericardial effusion that completely collapsed the RV, and as a result, falsely ruled out tamponade. Third mistake, you can acquire a nice apical 4 chamber and parasternal short axis. You interpret correctly that there's no RV strain in your patient, but incorrectly assume that just because someone with chest pain and swollen leg comes in short of breath because there's no RV dilation, that, oh, maybe I don't need to worry about PE. So missed a significant PE. Skills are not independent. They all build up, and it's going to default to the lowest common denominator. In these examples, someone would be mostly correct in acquiring, mostly correct in interpreting, mostly correct in integration. They could pass each of these exams very nicely, but final outcome was incorrect in all 100% of cases. All right, so I mean, obviously this is an exaggerated scenario, but that's the potential clinical or education outcome that could occur if we're not careful about what we're doing when we're assessing. What about reviewing images and sending in portfolios? So here's an example where, okay, the lung looks okay, probably. If I'm at home reviewing an image and I get these often, right, the learner will send it to me and I'll just pull it up on my computer and say, yeah, that looks pretty all right. But if I was there at the bedside and crank up the gain, and you'll realize, I don't know if you can see that from the back there, but you know, there was actually flickering of B lines that would have been missed if the gain wasn't appropriately high. All right. So I don't know, when I'm attending, I don't just kind of take my learner's physical exam at its word. Like, I check all my physical exam findings, or at least the key ones, maybe not every single one. I find POCUS the same way. Like, you know, yeah, sometimes I can't be there. I just can't be at the bedside every time. But when I'm at the bedside, very different interpretation can occur. Here's a learner who shows that, oh, the negative spine sign. So they're indicating that there's no significant pleural effusion. Diaphragm is here, the spine ends here, maybe a single B line. That was the clip given to me. And if you're just sitting there looking at that, so yeah, that's probably mostly okay. It's not the worst image. I've seen worse, but it does look like the spine maybe ends there. When you just take the time to rescan that patient, it actually looks very different, right? You can see B lines coming in, pleural irregularity right there, pleural effusion, a little bit of atelectasis at the base. So the conclusions can be quite different if you only look at images alone. Here's another learner, pretty high level learner. And I'm not bashing learners. Like, again, like this sort of thing can happen to me as well, could happen to my other attendings, right? Here's someone who says, oh, I can't get a cardiac window. And sometimes you can't. Like, a lot of patients have COPD, there's too much lung, you can't see anything. Fine, yeah, you probably tried the best. But sometimes it's not fine. Sometimes it's actually a really good window that it completely missed. Same patient, just put the probe on slightly a millimeter away and there it is, right? So it's really hard to remotely review images. I think we still have to do it because it's better than no review, but that alone, I am worried. It makes me uneasy. The other thing reviewing images doesn't tell you is that it doesn't give me a sense of how long the learners took to get there. If they took like an hour to get a okay image, that doesn't likely indicate competence. So only looking at an image as an inference of their acquisition skills is problematic. Portfolio. We all know what gets sent in, right? It's the left-hand side of this figure. We don't know what actually happens in general when people are scanning. So that's another issue that certifications that rely on people just sending in portfolio images for review is that they're giving their best foot forward. I don't blame them. I do the same, right? But it doesn't give you an idea of what they do clinically day to day. So all this just to say that there are some issues with certification, right? Reviewing images and portfolio alone, these are potentially problematic. I'm not even going to get too much into the usual other med-ed hurdles that we have in assessment. The very problem in med-ed is that we don't have a gold standard. I don't have a gold standard to say this is competent, this is not competent, and therefore if I apply this exam, whatever results, then I can get true positive, true negative, calculate my accuracy, likelihood ratio, and all that. We don't have a gold standard. That makes this very hard to do. There's also lots of statistical noise. Context is really important. I may be fully competent in a skin healthy individual, but if you have someone who is very elevated BMI or combative, I may come out with a completely incompetent scan. Skill decay is another big issue. on this graph is, this is intended to illustrate on the x-axis would be time, the y-axis would be competence. So after 1 month, our learners feel really good about their scanning skills. I do know that if they don't scan, it almost drops down to nothing. All right, so it's really, really important that we keep up with our scanning because skill decay is a big issue. So what do we do when does it seem like as hopeless as it is? Well, as educators, we spent decades on psychometrics and trying to have exam that has as much validity and reliability as possible. So there are ways around it. It's not perfect. And we try to have a programmatic approach to assessment. I'm not going to go too much into that. But one of the blind spots that we have in med-ed is we don't tend to remember to assess whether or not people know their own limitations, which I think for something like POCUS is absolutely the most important thing to do, knowing when to walk away and knowing when to say, I don't know this. How do they react to unexpected findings? Right. So I had a case recently where after paracentesis, the patient told me that, after you guys did the paracentesis on me, I developed acute scrotal swelling. And our house staff immediately dismissed the patient and said, no, that's not one of the commonly described complications. Right. But it was like the timing was really, really close together. And if you actually start digging into the literature, likely what happened was that hole in the peritoneum tracked into the fascia and the fluid continued leaking, causing scrotal swelling. Is actually completely plausible and absolutely likely that was what happened. But if you kind of dismiss things and you don't actually react to unexpected findings, you're going to miss opportunities, right? So in that case, I don't have a clip of that. If you actually scan that side, you can actually see the edema in the soft tissue in the abdomen on that side, but none on the other side, which again supported the hypothesis that there's this ongoing leakage. Evolving applications. POCUS is not a dead, it's not like this is all you have to learn. This is, you master that and you're set. It's constantly evolving, right? Internal medicine POCUS was not an entity when we first started. We had to build these applications in, and we'll continue to change these things. How do you react to evolving applications? So all that to say that certification alone is going to be problematic. Where do we go? I already went over, this is kind of what I call good POCUS hygiene, right? Just go through these things, take the time, be diligent, go through that. POCUS is not the wild, wild west, right? Like it's not like anything goes. There are some thought and regulations or thoughts and such that go into it. I'm going to give you my litmus test, right? Because POCUS, a lot of things weren't there when we first started. And how do we decide to develop and adopt something into our curriculum? These are the questions that I think are worth asking. One, if the new thing that you want to do doesn't actually address a need, don't waste your time. Okay, so that one's easy. I do have other things that I think are important. Two, is it actually teachable and learnable? Okay, people forget that. Sometimes they kind of bring in crazy high-level skill, and it's like, why are you doing this? So let's go over this. MSK, really, really common. You go to any MSK ultrasound teaching session. For the ankle, you have rheumatology in the room here, right? Like they will go through every single ligament, every single muscle, tendon. It is a very complex joint. Do we, as general internal medicine, need to know that? I would argue that we don't. I would argue that learning all those things is actually going to take away very valuable brain space that I need to be devoting to something else. For me, I just need to know, is there any fusion? Might be able to recognize some osteophytes and things like that, right? So I think we need to really be cognizant about what's relevant to us and teach accordingly. Again, same sort of thing. Just because MSK radiologists do it doesn't mean we should. We're not ever going to be as good as they are. Try not to replace it. Next question I ask is whether I or the average learner has the requisite skill to actually learn something, right? You need skills to learn skill. So here's a kidney transplant patient that we identified an abscess around the renal capsule. So my POCUS fellow was with me at the time, and we decided to put on Doppler. This is the transplant Doppler. And what you see is that you can see this waveform, Doppler waveform right there. I'm just gonna, I think a normal, yeah, this is what a normal waveform should look like. A normal kidney transplant should have a brisk upstroke and it should come down. What we're seeing is pulsus parvus and tardus, okay? And this is what radiology ended up getting, and they also called it pulsus parvus and tardus. This is the impact of that abscess on our transplant kidney. All right, fantastic. My POCUS fellow with detailed understanding of Doppler was able to get this. I don't think that our average 1-month learner should be learning and doing this necessarily. If they have the requisite skill, go for it. But you do have to think about baseline skill. Is the skill feasible or practical? I'm right now training a, sorry, you guys don't call it respirologist, you call it pulmonologist, right? Because when I say respirologist, everyone's like, what are you talking about? Pulmonologist. I'm training a pulmonologist who's doing a POCUS fellowship with me, and she wants to take a deep dive into the RV assessment. So these are just slides I've taken from my teaching talk on what you can do with the RV. You can measure all these things. You can do systolic, diastolic, hemodynamics, and stuff like that. Just because you technically can doesn't mean you should, right? So this is my take-home slide for her. It's like, what are the things that you should actually break it down to for a pulmonologist for it to be kind of, beyond the basic, but not crazy outrageous, right? So all these items in black and gray are the ones that I asked her to focus on and spend her time on and ignore everything else. Is there evidence for its use? Okay, if there's no evidence, we probably shouldn't be using that. So dyspnea, I'm not going to spend too much time on this, but there's good systematic review. ACP did a fantastic meta-analysis of data guiding, of POCUS guiding assessment of dyspnea, and use that to come up with the clinical guidelines on how it should be used, right? So that's good evidence for it. What about when there isn't evidence? I actually think that if you have something that is equivalent to clinical practice, it's actually really important to think about adopting without necessarily clinical outcome data. I'm going to embarrass Ernest here. This paper is absolutely fantastic. What he did was he actually looked at the correlate of ultrasound versus cath measurements of right atrial pressure. You can correct me if I'm getting any of that wrong. It's directly correlating what we do at the bedside, augmented by ultrasound. Like I think you were talking about, maybe not getting as much traction. I love this study. And if people don't understand this, my guess is some people are just not doing physical exam, right? But this is a very important study, and it's actually, I think it's fantastic. I talked yesterday also about this case. I had a 62-year-old female who was admitted with COVID, only on 2 liters of oxygen. This is the early days of COVID, right? Where we weren't allowed to bring our ultrasound machines in. We weren't allowed to bring learners. We were trying to not to get any imaging for any of our patients. But something about this patient didn't make sense, right? She was only on 2 liters of oxygen. Her infiltrates weren't significant. She had a positive abdominal jugular reflux for no reason. I couldn't figure that out. Sent her for a CT and she had positive PE. Physical exam matters. Physical exam is important. So therefore, having an ultrasound equivalent of that, I think it's fair game. I don't need a ton more evidence for me to start using that. Other things, when you're going to do something new with POCUS, do we know all the associated false positive, false negative artifacts and pitfalls? It's important that you take a deep dive and know all of those. For instance, something like learning, this is a tricuspid regurgitant jet, and figuring out what the tricuspid regurgitant maximum velocity is in determining RVSP. Lots of things you need to take a slightly deep dive to, just so that you really understand it. And then you're going to be able to come up with a very defensible statement. So our learners, usually our POCUS fellows, our average learners won't do this, but what the TR maximum velocity is likely at least, right? Because of understanding of underestimation and overestimation. The most important litmus test in my mind is, can I do harm with POCUS? That's actually very seldomly talked about, and I think it's absolutely important. Here's a patient with pyoderma gangrenosum. We had a patient like that recently. I didn't have an image of that, so this is from online. The POCUS, the medicine team asked us, like, can we rule out any abscesses in the collection? Learners were just about to start scanning. I'm like, stop, right? Need to ensure that your disgusting, dirty probe and that your multi-sample gel isn't squirted on this and causing an infection. So we need to think about the potential harm we do with POCUS, and you need to think about ways to mitigate that. Here's an eyeball that we were scanning, and this is measuring optic nerve sheath diameter. And depending on where you look online, there are lots of people who say, oh yeah, you just squirt some gel against the single bottle of gel, probably colonized with a whole bunch of stuff, squirt it in the eyeball and just go ahead and scan. I've never had a problem. That's kind of what we hear, right? Don't do it. Put a tegaderm on, right? Put some barrier so that you're not actually going to infect and cause conjunctivitis. Second safety endpoint, ultrasound does deliver heat. So make sure that you adhere to the FDA requirements, all right? So the applications on our machine doesn't guarantee that. If you want to look at the FDA article, that's the QR code there, right? There are specific limits that you need to look at your machine and make sure you're not exceeding that. So that eye example, so that people will come up with this article and say, hey, there's a randomized trial that looked at whether or not you used a barrier or not used a barrier. Guess what? If you used a barrier, the image quality sucked. It's significantly lower. For that reason, we don't use the barrier. Now, they never comment that the patient actually preferred the barrier. If you ask them, 54% rather you do that than not do it. But to be fair, even if patients don't prefer it, it's still, to me, an element of harm that I think we need to pay attention to. Okay, so I only actually have 5 minutes left. The talk's journey so far. I've talked about things that we can do as practitioners to be practicing POCUS more safely. When it comes to established protocols, these are the things we can be doing. When it comes to bringing in something completely new to internal med or completely new to you, there are things that we can do to make it safely. I've talked about the limitations of assessment processes and certifications. I'm not going to go over how to make a test more valid and reliable. I am going to touch a little bit about the programmatic approach to assessment. And it's really, if we do more assessments, the idea is that, we're less likely to have sampling error. And ideally do as many assessments as you can with as many preceptors as you can. The whole premise of this comes from the fact that if I have a big jar of candies in a room and each one of you have to guess how many candies is in that jar, statistically, you're more likely to be correct if we average the entire room's assessment on that actual real estimate. So statistically, the more data we put into it, we're more likely, it's not always the case, but we're more likely to be correct than a single estimate. All right, so that's the idea of the programmatic approach. But even then, I have big issues with all of this. I have spent a lot of my career thinking about how do I fix POCUS educationally? How do I teach it better? How do I assess it better? How do I create guidelines and make sure that everyone's kind of doing it the right protocol? I think that that's as far as I can get it with education alone. Okay, I think that there has to be infrastructure and policy that is going to be a systems-based approach to POCUS in order for it to be practiced safely. I'm going to liken it to a bit like, yes, everybody should have a driver's license, but maybe a dash cam can then allow us to see what went wrong anytime we have an accident. So to that end, I think workflow is really important. So radiology has a clear workflow. They don't ever scan someone and you won't be able to see it or see the report or see the images, right? But they have a very clear workflow. You put in an order, it goes to PAC, it goes to the machine, and then it goes back to PAC and it gets into the EMR. Well, POCUS has its own workflow, but we need to adapt our workflow to ensure that our images are shareable, viewable. right? So, but we can't always start with an order. This is the problem that the imaging world is facing right now, is that we can't start with an order. Sometimes we just crash into the room with a machine. I can barely even tell who John Doe is in the room. Like, I can't sit there and punch in the data and put in an order and say, order myself to go see see this patient. So therefore this encounter-based workflow needs to be the standard. To that end, I have been asked to co-chair a group called HIMSIM Enterprise Imaging in collaboration with FAIUM. This is the first of our series of white paper on trying to define standards on workflow so that this won't be a problem. I don't know how long it will take, 10 years maybe. I don't know. These things take forever. But hopefully we're not going to be facing these problems down the line, that, you know, there needs to be a system solution for this type of stuff, so that whatever I scan, like, hey, I'm prone to making a mistake. Ernest can take a look at it and say, oh, why did Irene call that? That was ridiculous. I'm not going to do this, right? So there should be checks and balances for us to kind of check each other's work so that patient care is optimized. So that's all I've got for you. I hope to have kind of convinced you that for one, I didn't totally convince you, but the POCUS is clinically powerful. This is a hill I'm willing to die on. The number of cases of patients that I have saved and come up with like the right thing for that patient is countless at this point. However, the flip side of the coin is also true. When you do it badly, you can cause significant harm, and that's what keeps me up at night. So there are things that we can do as individuals to make POCUS safer. I also think that there are things that the system can do to kind of make things safer, and really combining our individual efforts along with system is probably the preferred approach. So thank you so much for listening, and happy to take any questions.